or any other anatomic reasons in the tricuspid anatomy are the objectives. Of course, we want to help our patients. So the first objective is, I think, always to improve the quality of life, but also improve the myocardial association functional class, improve 6-minute walk test, but maybe we can also improve survival, which I think would be the ultimate goal. These are the two valves, and I will come back to that in a minute. They're dedicated for the superior and inferior vena cava. As I said, to avoid backflow, reduce congestion, we could show that it promotes right ventricular remodeling. We have an increase in cardiac output, and we have a decrease in symptoms, and hopefully it can be shown in mortality. This is a publication that will soon be published in the European Journal by Dr. Amat Santos and his team, showing that in the CT analysis we could show a reduction in the right heart volumes from 6 months to 1 year after treatment. So just to explain the design, you have here on the left side, from your side, this is the SVC valve. This has a very dedicated design, which is with the so-called crown, which will go into the confluence of the brachiocephalica. Then you will have the belly here anchoring in the part of the superior vena cava. Anchoring here the belly in the superior vena cava. Normally it's a good landmark to put a catheter in the right pulmonary artery. So this will really give you a nice landing zone and will also show where to deploy the belly, and then the valve bearing segment facing toward the right atrium. Why does it have such a long skirt? So to prevent paravalvular leakage, and still you have hindered inflow of the brachiocephalix, and if so, also an inanimate vein. And then the anchoring zone down here. It's an open cell design, and all the valves are fully retrievable, retrievable, and repositionable. And for all of you who are doing TAVI, this will be a very relaxing procedure because you have a totally stable patient, you have all the time, and actually the slower you do the procedure, the better it is. Very important, as I already mentioned, all the valves are done with the proprietary dry tissue technology, which means that everything is done in-house again, harvesting in the slaughterhouses. We choose the pericardium according to the valve position, so you will have a thinner pericard for the venous valves and a rather more robust pericard for the TAVI. All the chemical fixation and mechanical and biological testing are done in-house, as well as the chemical drying and antimineralization process. So there's also, of course, lipid removal in order to increase the durability of the valve, because this will be the main issue for the future. Can we increase the durability of the valve? Can we make it long-lasting for younger patients to be treated? And here it is clearly shown that also after rehydration, the pericardium actually has the same properties as it had. Has been successfully completed for all the valves. This is how the device actually arrives in the cath lab. So very easy, off the shelf. You rinse it for 3 minutes with normal saline, no ice water needed, and after 3 minutes the device is ready to be used, which I personally think is a huge advantage. First, you can decide in the last minute which valve, which size you want to take. You don't need additional people in your cath lab, and nobody touches the valve before it's implanted, which I think is also important. I would like to guide you through the screening process. Screening is very easy for a trach valve patient because As already mentioned, the tricuspid anatomy is not really relevant. You just want to make sure that you have severe tricuspid regurgitation, so severe to torrentious. You have to have the backflow into the cavas, so you want to see a reverse flow in the hepatics. And you want to have a right ventricle that is still, I call it, viable. We chose a TAPSE of 12 as a cutoff value. TAPSE is not always very reliable. We know that if the patient had prior tricuspid annuloplasty or left valve repair or operation, then TAPSE might not be the very good marker. But what we need to keep in mind is we have to have a right ventricle that can still cope with the closing of the backflow. So TAPSE around 12 is, I think, a good marker. We recommend an SBAP below 65. Why? Because I think it was also nicely mentioned, I think that patients with primary pulmonary hypertension will not benefit from a tricuspid intervention. So this is simply to have a cutoff to differentiate between the patients with tricuspid regurgitation and patient with a pulmonary problem that needs to be addressed. Very important is a right heart catheter with the measuring of the B wave in the cavas, because you want to make sure that there's a backflow into the cavas. So a cutoff value of 15 millimeters of mercury is recommended, and this should be done in a patient in a normal diuretic status. So it's no need to bring the patient super dry to the table, nor to stop diuretics. You want to know what the patient really has. This is the sizing. So we offer a platform where the CT scans can be uploaded in an anonymized way. They will be measured, but as you can see here, measuring is a very easy, straightforward procedure in order to define the valve sizes. At the moment there are 4, so 2 and 2 valve sizes already under the CE mark, and the other valve sizes are currently in the compassionate use program and will be added to the CE mark as soon as MDR is valid. Just to give you a short overview over the landscape, I mentioned here the compassionate use program because I think it's very important to see that around the world patients have been treated in this so-called compassionate use special access program. That means that each and every of those patients has been submitted to the health authorities and has been approved by the health authorities. And we didn't have one single patient that was denied. And at the moment we're doing a lot of compassionate use patients in the United States. So there's a very close relationship with the FDA that has also given the device the breakthrough device designation. And I think that this is a proof that there are a lot of patients in need. If we look at the clinical trials, then this is the first in human study and the CE mark study that led to the CE mark. Currently ongoing the TRICOS registry, including 450 patients in real life. And then I think it will be very exciting to start the TRICOF trial. It's the IDE trial in the US, Canada, New Zealand, Australia, and probably Japan and some countries in Europe under the guidance of the Cleveland Clinic. Just to guide you through the data, because I think it is very interesting in the light of the Triluminate data that have been published recently, or 3 days ago. And this is the paper that was originally published in JACC. And on behalf of the investigators, I would like to give a short introduction. So as I said, that was 35 patients, single-arm, non-randomized trial. Classic parameters, age-wise. The majority of the patients were in AFib. That is important because first, all of the patients received exicol should stay on lifelong oral anticoagulation. But if we look at their baseline criteria, then it's very obvious that up to now 100% were already prior to the procedure, and you can use either vitamin K antagonists or DOAC. Both is feasible. Otherwise, you see that a high percentage of the patients that were treated had prior valve surgery, more than 50%, and you also can see that you had almost 1/4 of the patients with pacemakers. So pacemakers are no contraindication, and hepatic vein backflow was present in almost all the patients. If we look at the safety, now worldwide, I can tell you that there were no procedural deaths. So it's a very safe procedure, which is very important. It can be done in local sedation, it can be done with transthoracic echo only, so it's a minimal harm to the patient, which, if you look at the patient group, is extremely important. There was no device-related mortality. That was actually cancer and trauma that is seen here. Major bleeding is one point, and the most frequent side effect that was seen is a transient shoulder pain, which is most likely due to the compression of the nervus phrenicus when you deploy the IVC valve. So we recommend the pre-treatment with pregabalin for 2 days before and after the procedure. But if you look at the results, then I think you have to keep in mind that those patients were far more advanced in their disease than any other patients treated in a clinical trial up to today. So you can see that all of the patients were in NYHA stage 3 and 4, and after 6 months, almost 80% of the patients were in NYHA stage 1 and 2, which I feel is remarkable. At the quality of life, we could see a delta of more than 17, improvement in quality of life, and I can tell you the 1-year data will be published now, and this is sustainable for 1 year and beyond. 6-minute walk test was not significant, but it did improve. We have to remember that all of these follow-ups were done during the COVID pandemic, so the patients had a very strict stay-home order, especially in Spain and Austria. They were only allowed to leave the house twice a week for shopping. In conclusion, it's a very safe procedure. It showed a significant improvement, and there was no device-related mortality. I tried to, and this is the TRICAF trial, just to mention this shortly. So this is the US trial, which, as I said, will start enrollment in summer. It's around 200 patients. We will have to discuss with the FDA in the light of the Triluminate trial now with a 1-to-1 randomization. I'll just skip this part here because I think this is always the same inclusion-exclusion criteria. This was actually while the Cleveland Clinic feels that it's very important to bring the device to the United States. They were, of course, participating in all the trials, especially in the Triluminate trial, which has now been published, and the TRISCEND trial. And they said that up to 80% of the patients were screened out and were not eligible for neither technology. And I also think that for the orthotopic valves, we will have to choose very carefully which patients to treat. So we will see in the future. I tried to put a little bit in relation the Triluminate trial and the TRICOS trial, and of course Triluminate was a randomized trial, more patients, but just to see a little bit where the differences are. And I think age-wise everything is the same. We had by far more women in our trial, probably due to the fact that the patients were sicker, more advanced, and we know that this is then more women that are in this patient group. The cancer score, if you look at the cancer score at the baseline, then you see that the Triluminate patients were much better in their general well-being than the patients in the TRICOS trial. Hypertension was the same. Kidney disease, it was the same. Of course, patients with tricuspid regurgitation tend to have a high degree of kidney disease. Liver disease, AFib, same. Pacemakers, of course, in the TRICOS group, 23% versus much lower rates in the Triluminate trial, and then prior valve surgery, approximately the same. If we look at TR severity, that was also similar, where I think the coaptation gap, all of these parameters were similar. Where I was really astonished was that you had more than almost 50% of the patients in the Triluminate trial were actually at New York Heart Association 1 and 2 at the time of their inclusion, which showed that they were rather early in their disease when you compare them to other trial data. If you look at the change in the KCCQ, then you have a change of 12.3 in the overall device-treated population. In the population where you could reduce the TR significantly to TR 1 or 2, you had a better improvement. In the control group, we see that this is poor. So I think in the end, it's not fair to not treat our patients, because you can clearly see that there is no benefit in optimal medical treatment. If you look at the TRICOS study, as already shown, improvement was higher than seen in the triluminate patients, although they were much more advanced in their disease. And also, if you look at the 6-minute walk test, patients did better after trach valve implantation. Of course, all of this will have to be proven in bigger numbers. Very normal that we have to learn. We have to learn which patient will benefit from which technology. I mean, we have learned, all of us as cardiologists have learned that there's always also therapy involved, that we have to personalize to the patient. But I think we have identified the unmet clinical need, so we are moving to new technologies and we will change paradigm. Thank you very much.
Thank you. How long is the longest follow-up what you have on this?
Yes, actually yesterday we had a very nice presentation of the first patient treated in India, 2018. And at that time it was a lady that came for liver transplant to India, was denied treatment of her valvular disease and her liver transplant, and got the first trach valve implanted. That was early 2018, so it's now 5 years. And we saw a picture of her 3 days ago, happily living her life alone, self-dependent, in a very good position. So I would say, look, the first patients implanted with 2-valve were 2014. We actually had a follow-up of that patient until 2 years ago, so I assume the lady was 84 at the time of the implantation. We had a 6-year follow-up of the patient, so I assume she will have deceased by now. But 5 years is a realistic goal. Most of the patients are now in their 3 to 2 year follow-up.
What are the long-term effects of the atrial dilatation, utilization of the ventricle?
Yeah, I mean, that's a very important question. First of all, if we have torrential TR, then of course we already ventricularized the right atrium, even before we put the trach valve. What we see currently is that once you put the valves, you block the backflow. So the first thing that happens is that the right atrial pressure rises, which is normal. So, but obviously the right heart can cope very well with this temporary rise in pressure, because we have I think our need for inotropic support is below 1%. So very few patients need inotropic support during or after the procedure, which for me, in my understanding, is a sign that the right heart can cope very well with this situation. We see in the first 6 months that there is a change in the hemodynamics. So what you see first, directly after trach valve implantation, is that peripheral edema, ascites, and jugular pressure get they are completely diminished. Then the next thing is, what you see is that there are hemodynamic changes. You can reduce the diuretic stepwise. I would not recommend to do this immediately, but really over the first weeks. And normally after 3 weeks you have the most benefit already, where you have lower diuretics and lower pressures, and then you see already that the pressures get lower and the ventricular diameters will follow the pressures, as Pepe Zamorano says.
Any other questions from the panel?
Katrina, that's a fantastic presentation. When you screen these patients, quite often we find this SVC valve, the anatomy is not suitable. So if you just give the IVC valve alone, I've seen in your studies some of the patients had only the IVC valves. How is the outcomes in those patients, just IVC valve alone?
As it's a very good question, because normally we recommend to put both valves. But of course, if you look at the pressures, then it's 2/3 to 1/3. So the IVC valve will always have a higher proportion in the reducing the backflow. IVC valve only we did mainly in patients with carcinoid or other underlying disease, or in very rare cases where the SVC was really not suitable. I would say what happens is that sometimes the IVC is so dilated that you cannot implant anymore. But this is for me a sign that we have passed this point of no return and are already too late in the disease. So there is no series of IVC only patients. What we will do now, one in London with Andreas Baumbach, and another series in the United States, because we have submitted for the HDE submission, is in carcinoid patients. And of course, carcinoid patients having a completely different underlying pathophysiology, they normally have narrow SVCs that are too narrow to implant the valve, but they have large IVCs, and especially they have those leaflets that are just open because they are invaded by the cells and are just stiff. So this will be a series of IVC valves, but of course it's a different underlying pathology. So
Thank you.
any more questions?
Thank you very much. Can we have a big round of applause, ladies and gentlemen, for Dr. Katrina Kiss. We're going to be moving on with our next speakers. Joining us will be Dr. Pratish George and Dr. Nathaniel. Dr. Pratish George is a consultant interventional cardiologist from Christian Medical College, Vellore. Is actively involved in patient management research and cardiovascular intervention. He's performed more than 1,000 simple and complex angioplasties done as a first operator, and also assisted more than 200 complex peripheral vascular intervention and endovascular aortic repairs. Performed and assisted more than 100 device closures for ASDs, more than 200 balloon mitral, aortic and pulmonary valvuloplasties, and part of the Heart Valve Structural and Complex Coronary Interventions Unit at CMC Vellore. Thank you so much, Dr. Pratish, for joining us. Our moderators for this session will include Dr. Anantharaman, Dr. Ajit Pillai, and Dr. Chandrasekhar.
Good evening, one and all. Thanks to Relisys team for giving me the opportunity to present here in front of such esteemed faculty and in front of a lot of my colleagues. So this is, I'm from Christian Medical College, Vellore, and these are a few of the interesting cases we have done at our institution. So we'll start off with a case, a different kind of tricuspid valve beast which we have to tame. So this is a 60-year-old post DVR with Star Edwards valve in 1988. On long-term follow-up in CMC since that time. He is currently symptomatic for 2 years, worsening to class 3. Creatinine was 2.5, probable cardiorenal. He has hypothyroidism, 2 heart failure admissions prior to our visit to our hospital. His INR was 10, more than 10 when he visited, so we raised a suspicion for hepatic dysfunction. AST, ALT was elevated, albumin was low, urine protein was negative, liver span was 12 with early features of cirrhosis and mild ascites. This is ECG showing atrial fibrillation or flutter. X-ray, actually not much cardiomegaly, there is some amount of right atrial dilatation. So this is the echo. So this is a thickened doming tricuspid valve. This is with severe TR and severe TS. So his mean gradient was 5, the tricuspid valve mean gradient is 5, with a TR max of 25, low pressure TR. TAPC was 17, RV function was preserved. And this is, there was systolic hepatic vein flow reversal, which I think is a very interesting and common finding, and it does help to prognosticate the patient, in my opinion. It was a norm, and both the ball and cage valves implanted in 1988 were still functional, more than 30 years, and with very low mean gradients. He had normal left ventricular function. So right heart catheterization and the RV angiography. So we can see that the V waves were around 17 in the SVC, RA it was around 17, IVC 11, RV systolic pressure of 34, EDP 10. The PA pressure was only mildly elevated, it's only 26 mean. PCWP was 18, and the cath gradient was around 11, RARV mean gradient. So there was severe, and you can notice the normal poppet valve function, you can see the severity of the TR. So this was a different kind of, this was severe TR with severe TS, which is peculiar to rheumatic patients. And so we had our heart team meet. His risk of mortality was high, 8.5%, and he was turned down for surgical valve replacement in view of his advanced stage. And so the family decided to proceed with trach valve implantation. So this is our planning, this thing. So we decided to choose the valve size appropriately. There were no anatomical challenges for the valve implantation. So this is interesting because we decided to sort of change this into something which the trach valve can treat, is certified to treat. So we wanted to convert the tricuspid stenosis into as less as possible. So we used the largest ZMET balloon we had. We opened it up to the maximum pressure, 4 atmosphere, opened the valve, and then we did the implantation. A 29 mm SVC valve was deployed. As all the experts have spoken prior, the key is a slow deployment, allowing the nitinol frame to gradually expand. You can continuously shoot from the EJV. Many people would put an right pulmonary artery catheter for this thing. And another important step is to recapture the nose cone in the RA and not to bring out the device. IVC valve, again fairly straightforward. So we use a 35 mm IVC valve, marked hepatic vein with a 6 of MPA from the left side, and slow deployment with constant checking. That's the key here. Taking our time to deploy, and small amounts of pull-push by the first operator as the second operator slowly rotates it anti-clockwise. So we can see that it has been deployed. Fairly straightforward mechanism compared to TAVR. There's no need for pacing. Patients are always hemodynamically stable. They do not decompensate, their BP does not drop. So quite straightforward. So this is the final angiogram. There is absence of systolic reflex into SVC and IVC. So interestingly, usually what we see is the RA pressure goes up as soon as we do the trach valve implantation, but for him it only went up to 16. So this probably could be because the TS is still there and RV is emptying more into the PA rather than for reflexing back into the RA. And we achieve hemostasis easily with a single 1 or 2 figure of 8 sutures. So post-procedure is where this is stormy, because patients have been adapted to a low pulmonary output for a long time, and then once we put this trach valve, we are suddenly obstructing their outflow. So all the blood, the output goes into the pulmonary artery more, or this is what we think the reason is. So the tricuspid valve was open. You can see that the laminar, the TS has become laminar now. There is no turbulence for the TS. The TR is severe. The systolic flow reversal was abolished in the hepatic vein Doppler. I think this is a good thing to look for the prognostic, for the success of the procedure, because that is the most important pathology which is affecting the liver. TAPSE was 17. This is another thing. Generally, there is also a reduction in the RV systolic function when we do this trach valve. But this gentleman, TAVI, it was preserved. Valves were seen with no paravalvular leak. We always put the patient's ICU post-procedure. Aggressive diuresis is required. This gentleman required some inotropes to maintain renal perfusion. Over the next 3 weeks, he lost 8 kgs. Albumin had to be given IV. His cardiorenal syndrome improved. Creat improved to 1.5. AST, ALT came down. Albumin became 3.4. His INR was more than 10. It's now 1.4, and we restarted warfarin this time. Now he has completed around 1 year of follow-up, and he has no more heart failure admissions, and he's ambulant. So that's our first case. It's a kind of a different kind of tricuspid pathology which could treat with the trach valve successfully. So case 2 is a 70-year-old gentleman, lady, primary hypothyroid, post DDDR for symptomatic bifascicular block, new RV lead implantation 2012. So right from this 2014 on our follow-up, they noticed moderate TR, probably due to the impingement of the lead. But as we tend to do, we tend to manage most TRs conservatively. She had a PG change recently in 2018, And then she became symptomatic from 2020, from the COVID time. Progressive dyspnea and fatigue with pedal amoeba, abnormal distension. Creatinine was normal, AST, ALT was normal. For her, it was sort of a hepatitic kind of, her liver span was actually more with parenchymal changes and dilated veins. So this is kind of the, it had not evolved into a cirrhosis kind of phase. TSH was also slightly high. This is a ECG, A-paced, V-paced ECG. X-ray, again, some amount of right atrial dilatation. You can see the 3 pacemaker leads. It becomes interesting as the case goes on. There are 3 leads coming through the SVC. So echo, dilated RARV, torrential TR. The leaflets are actually normal. There is no thickening. So there is a large central non-coaptation, probably lead induced. TR gradient was 20, TAPSI was 19, S prime was 10. Again, systolic hepatic vein flow reversal was seen, and 2 CID leads could be visualized, normal left ventricular function. This is the right heart cath. Again, the V waves around 14, systolic pressure 42, EDP is 14, little high, and mean PA pressure was 22. PCWP was again 14, grade 4 TR. Heart team meet, risk of mortality 8.98, turned down because she needed extensive surgical work, lead explantation, tricuspid valve replacement and epicardial pacing. So family decided to proceed with tric valve implantation. This is the planning sheet. So here a challenge was there because SVC RA, the confluence was 6.7 centimeter, and the as far as I understand, the covered part is around same. It's around 67 or 65 millimeter. Correct me. I'm not. I think it's the same. So so this is the SVC deployment. 25 mm SVC valve. Again, slow deployment. We already have the leads as a marker, so we started deploying. Constant check from EJV. As many experts do, they can mark the RPA. We don't usually do it. Again, important to recapture the nose cone. This patient had actually occlusion of the left brachiocephalic. But if you keep looking here, you can see that there is almost immediate compensation by opening of collaterals from the left IJV to the right IJV. Probably the thyroid veins or some. And then we can see that the flow reverses and comes back into the internal jugular and to the SVC, back into the RA. So this is IVC valve, 31 mm valve, hepatic vein marked, slow deployment. He had a very huge hepatic vein, so even if it was partially covered, it would not have been a problem. So this is a final angiogram. Absence of systolic reflex again, maybe trace. Post RA pressure was 41, so this patient, it became equal to the RV systolic pressure. Hemostasis, recently we have started using proglides for venous access, so close to single port, but generally we don't need. There was successful, so this patient had successful implantation of the tric valve across 3 pacemaker leads there are 3 pacemaker leads which go across the SVC RA junction. And there was no change in, also important is that the valve has not interfered with the impedance of the leads as well. There was both less than 400 ohms post-procedure. Post-procedure again severe TR. I wish I could show the images that hepatic, the flow reversal changes, so that flow reversals get abolished. And this patient had RV dysfunction post, her TAPSI reduced to 12, S prime reduced to 8. Again, she was in ICU. She developed pulmonary edema post-op day 1. So the post-procedure course is generally little stormy for this patient because suddenly we are changing the hemodynamics of the patient. There is increased pulmonary blood flow to which they are not adapted. So she needed aggressive diuresis, non-invasive ventilation, gradual improvement over 2 weeks. She did not have left upper limb edema, facial congestion. Pemberton sign was negative at time of discharge. She has completed around 3 months follow-up. Thank you.
Very nice cases, fantastic, congratulations.
I think it's very nice what you showed with the pacemaker
Thank
leads, because I think this is also very important. I mean, the first case was amazing to see that what can be done, but it's important for the pacemaker leads and also that it's possible to put the pacemaker lead afterwards again through the SVC valve if really needed, but then also leadless pacemaker. But very nice cases. Congratulations.
Thank you.
Thank you so much, sir. With this, we're closing this session, if in case the moderators would like to add anything. All right, moving on. Our next speaker is Dr. Anantharaman. Dr. Rajaram Anantharaman, Senior Consultant, Interventional Cardiologist and Director of Advanced Heart Failure, Cardiomyopathy, Circulatory Support and Transplantation from Kaveri Hospital, Chennai. Advanced heart failure and transplant stem cell cardiomyopathy therapy is his specialty. Experience and competency to be a sole operator in the following interventional cardiac procedures. First operator for 3,200 plus, femoral 30% and radial 70%, TAVI 100 plus, both Edward Sapien and Medtronic core valve, and IVUs N450 plus rotablation, N equal to 110 plus. Dr. Rajaram Anantharaman is our next speaker, and this session will be moderated once again by Dr. Ajit Pillai and Dr. T.R. Muralidharan.
Thank you. Good evening, one and all, and it's nice to see all familiar faces and close colleagues. I'll not take much time. Can go to the slides, please. It's a very familiar topic, so commissional alignment. I don't think we need to go through in detail or teach you. The importance of the commissional alignments in the talk is going to be, it's not about the coronary access alone. So commissional alignment is not just for coronary access alone. It plays a vital role in terms of the durability of the valve, the paravalvular leak, all the other associated outcomes. Can you open it? Yeah. So the surgeons do commissional alignment 100% of the time. Whenever they do the surgery, commissioners are aligned and they do the alignment. But in terms of TAVI, next slide please. Yeah. Which one? So this is how obviously you get a good commissional alignment, the green is good, there's no flow issues. The other side is the not working. It's okay. Yeah, that's okay. So if you don't do that, then you will run into trouble. Now, as I said already, it's just not for the coronary access alone. It's also kind of for future TAVI in TAVI, as well as for reducing the sort of halt and improving the durability. For all the other reasons, your commissional alignment is very important. So how you do it, obviously, as I mentioned here, these are all the outcomes. If you do a good commissional alignment, you get a good coronary access, your flow is good, not much central leak, you can avoid paravalvular leak. It gives access for future basilica and TAVR in TAVR, as well as the leaflet strain is less. For balloon expandable, it applies the same. If you don't get good commissional alignment, then you get bad outcomes, and that's very well shown in the studies. So even if you're not a structural interventionist, you need to know this, because the number of TAVIs are increasing, and you will come across a case where you have to reaccess the coronaries. So please do go through it and understand the different TAVI valves and how you access the coronaries. So the major important thing is the THV commissions due to lack of commissional alignment. This, I think, most of you would have seen the depth of the implant, the sort of original your anatomy, and your leaflet length, and also the sinus diameter. All this matters. I'll just skip for the purpose of the time. So different valves, you get different alignments. Whenever you do valve in valve, it also affects it. I'll just skip all this because of time. Now this is very, very important. So if you get a good commissional alignment, I just want you to concentrate on this bottom panel, not for the first procedure. When you do the future procedure, if you had a good commissional alignment, you will be able to tear the leaflet properly. You do a good basilica and you can put a TAVR in TAVR. First time around, if you don't get a good commissional alignment, forget about your second TAVR in TAVR. So this is how you do it, balloon assisted basilica, then you can easily put another balloon expanding valve in the previous self-expanding valve. Now, valve in valves, obviously if your previous valve is kind of tilted, or if your new valve is going to be tilted, it will affect your commissional alignments. Now, they tried crimping the valve at a particular position, and did it really affect? Obviously, crimping it in a 6 o'clock, 12 o'clock, 3 o'clock, it didn't matter for the balloon expandable. So the S3 has stopped doing that. The S4 is coming up with a new C-tab. So the balloon expandable S4 will have a C-tab for you to do the commissural alignment. So that is how it will look. There will be a C-tab with the new S4, and as long as you align it anterior prior to valve deployment, you will get a good commissural alignment. For the Evolute, they were the first to come up with the commissural alignment principle. The Evolute introduced the C-tab marker. Now all the other self-expanding valves are starting to copy that, and it's very, very vital that you get a good commissural alignment. So there is a 90 degrees, the C-tab and the hat markers are 90 degrees to each other. So whenever you're doing an Evolute, make sure that your flush port is at 3, your hat marker is outside, and after valve deployment, your C-tab is on the inner curve. If you do that, 90% of the time, your commissural alignment is done. So that's what I just mentioned. 3 o'clock position, hat marker out, after release, the C-tab on the inner thing. How do you do in terms of, this is a newer one, you get the coronary alignment. If you get very significant eccentricity, you don't go to the cuspal overlap, you do the coronary overlap view. The coronary overlap view can be achieved from the CT scan. So rather than going to the cuspal overlap, if you go to the coronary overlap view and then implant it, you will get a good commissural alignment. So this is one of the cases of Gilbert's, obviously. Try doing it in the cuspal overlap view. You try to cross it. I want to concentrate on this particular one. This is the hat marker. So the flush port was at 3 o'clock. When it goes down, it comes to the inner curve. So if you deploy with that, you will not get commissural alignment. So you come back and rotate the catheter. Now it is rotated to 12 o'clock, which we used to do in the past. And see the hat marker coming out. So this hat marker is out. And when you go to the cuspal overlap view, it should be front. So if it's in the front, then you are fine. And that's a perfect sort of alignment. So this is the new valve, which will have this marker as well. That's a new marker, depth marker, that comes in the new flex with the Evolute. So that is the next version of it. In terms of the other valves, how do you get it? Obviously for the Accurate Neo, you have it the flush port at 6, and for the Portico at 12 o'clock. And also there are other things you have to look at for the Accurate Neo and the Portico. The other important thing is this free stent. The free stent should be on the inner curve, and for the Portico, the post should be on the inner curve. So if you get this right, then your commissural alignment is fine. That is what these sort of pictures represent. So all this can be done. How do we do it with the bicuspid valves? Obviously through the CT, you can do the coronary overlap, and through that you can get a good commissural alignment. So I'll skip that for the purpose of the time. It's very, very important. Obviously anybody doing TAVI, go through Gilbert's paper, which is published in 2022. It goes through in details about your commissural alignment as well as the coronary kind of overlap and alignment. So you need to be knowing about these things. So important take-home message, commissural alignment is very important if you want to reaccess coronaries and to get a good outcome. And for the Medtronic, it's 3 o'clock. For the Accurate Neo, it's 6 o'clock. And for Portico, it's 12 o'clock. Thank you.
Absolutely fantastic, Ananth Raman. Fantastic. Thank you. I think we also have now for commercial alignment for MyVal as well. We have just sent for publication. It's just in the process, so it can be adjusted based on the CT and loaded appropriately, and then you insert and get a commercial alignment.
The depth marker is there. So whatever the adverse try to come up, the MyValve adds one more. So it has got the commissural alignment as well as the depth marker as well. Thank you.
Thank you very much. I'd like to check if Dr. Ajit Pillai and Dr. T.R. Muralidharan, our moderators for this panel, would like to add any comments before we move on to the next speaker. No, sir? All right. Okay. We're now going to be moving on to our next speaker, Dr. Nagendra Bhupati. I'd like to request him to kindly join us. This session will be moderated by Dr. Sundar and Dr. Shanmugasundaram.
And you possibly a romantic one gone for calcification later. Coronaries, coronary is non-obstructive CAD, no issues at all. So this is a CT scan of a particular patient. You can appreciate some amount of calcium near the node side, and there's a good amount of calcium that starts appearing in the base of the leaflets. And as we ascend, you can also appreciate thickened, most like the rheumatic one. All three leaflets are. Obstruction valve is 0.5% for empty valve, mostly 0.5% for valve and valve. If you visit the water and it is 50%, we all know the believe when a coronary obstruction can happen. It can happen with the sinuses short, STJ short, very small STJ. These are on the tall leaflet and a very short left main or RC origin. These are all known data. So what is it? Other than acute coronary obstruction, we should also know about delayed coronary obstruction. There's a good amount of data available. Virtual coronary, virtual valve coronary resistance. These are all the values what they found, and you can go to the specific available in Jack. They found that for left main, slightly different from the right coronary artery. And there's another important new concept what they propose is cuspal height. None of us see cuspal height. Cuspal height is the most important predictor what they found in this particular paper out of the patients. Most of the patients, whenever the cuspal height is going to be higher than the, cuspal height is going to be higher than left main height, these are all the patients where whom they found significant coronary obstruction happen. So they propose an algorithm to predict the patient who can have potential coronary obstruction. How? Look for the cuspal height. The different way of looking for cuspal height, the idea what they have proposed is a novel one. We can go through the paper. They go from the annular plane and go to the tip of the leaflet and measure the height vertically rather than measuring the leaflet height like that, and then minus it from the left main. If at that point of time the height is going to be higher than the left main height, then they go to virtual valve to coronary distance. If it's going to be less than 4 and the sinus is going to be borderline, the chances for the patient is going to have coronary obstruction is going to be high. This is a new prediction model. I think most of us should be using this algorithm. It's very, very useful. So in such patients, we should go for a SAVR if the patient will be low risk, high risk, or even for high risk surgical anatomy. If the patient is going to have high risk coronary obstruction, if the required expertise is not available like in Basilica, then it's better to go for a SAVR rather than TAVR. Basilica, the available data says it's very safe procedure. And chimney, the available data is only as a bailout procedure. It should not be planned as an elective procedure at all. Capping is a new procedure. We will go through one by one. In the index patient, we found that left main occlusion like this. That luckily we could get the guide, the smaller guide, directly to the left main, and then we wired it, ballooned it, and stented it in single stent, and fought it. We did IVOS, and then the result was good. We had 1 year follow-up now. He's doing good now. Where I went wrong with this particular patient, I expect of having a glitch that the leaflet is quite thick on the tip, and the left main height is 12, and the leaflet cuspal height is going to be more than the left main height. I missed that particular point. Now we should not. That's the reason why it happened. So now we should also know about data regarding chimney. So what I did in this particular patient is chimney. There is only for bailout, never ever for elective procedures. Or we should go for Basilica if at all is required in a low risk or intermediate. We should not send the patient for SAVR rather than doing elective chimney. The available data says the 1 year survival is 85% in such patients. Case 2, thanks to Mount Sinai team, especially Jafar Khan who cooperated us in this particular case. 81-year-old female, diabetic hypertensive, had a very small, very short left main, 4 millimeter. For one time, I'm not going through the procedure in detail. We performed a Basilica, put a sentinel, performed a Basilica using a standard technique. It was Jafar Khan who did the entire thing actually. It was very complex procedure. It took some time for me to understand what exactly was going on in that. So the catheter there is not AL2, it's a backbone catheter, dedicated catheter from Medtronic for Basilica procedure. We perforate the leaflet with electrocautery, and then exterior is you can see the flying V going there. This is the third video is the flying V going there. And then self-expanding evolved valve was deployed in this particular patient. She did well. We had a 6 months follow-up till I was 2 years before, 3 years before. She had a 6 months follow-up. I don't know what happened here. The 75-year-old female, another patient who had a cabbage done. Now cardiogenic shock, severe sepsis, had a fracture also. So in this particular patient, we didn't go for TAVR later. Initially, we performed a BAV as a bridge therapy, and then proceeded with TAVR. We got a CT scan done. So after this BAV, she went for a femoral open rotation internal fixation of the hip joint, and then we planned the TAVR for this particular patient. If you look at this particular anatomy, this is a very narrow, very small SOV. And the height of the STJ is 16 millimeter. And we placed a 22 millimeter circle, and we measured got only 1.8 millimeters VTC. So whatever Jafar Khan found is there in this particular anatomy. Very small sinus and a very small virtual VTC. We initially thought VTC is only for valve valve. VTC can be placed for native valve, of course. So and it's very short STJ. We presume, and this patient has got a patent lima. That is the reason why we went for a TAVR too. So then we thought there valve -1 cc, there was a PVL, we post-dilated it. Then we observed this white line sign and pressure dropped down significantly. We have to escalate NORAD. With escalation of NORAD, she got stabilized. Now, Dr. Latif from Montefiore Medical Center has described a technique where he protected the left main, and then later on he took a ping pong guide technique and wired the left main through the valve rather than doing a chimney. That is called a stab technique. So what happened to this particular patient after deploying the valve is, the stent is here, wire is here, the red one is the native leaflet, it's going and obstructing the flow. The yellow one is the native leaflet. So what chimney does is, chimney is protruding a stent all the way above the frame and deploying the stent like that. The problem with chimney is, re-engagement is going to be a hell of a problem, and we don't know what is the natural history after 1 year. What Latif proposed is, keep the guide there, take a second guide, go through the valve and do the procedure. It's called as tapping the left main. So we performed, since the patient allowed us, the hemodynamics allowed us, we took a second guide. We thought, let's try that one. We wired the left main through the valve this time. We could wire it, then we deployed the stent from the left main through the native valve, through this newly placed my valve, coaxially into the left main. In that process, while retrieving the first stent, before deploying the second placed stent, when we tried to remove the first stent, the stent got dislodged and it was located inside the left main itself. However, our second stent was there, so we plastered the first stent inside the left main with the newly placed second stent. So post procedure there was no issues. She did well. Discharge after 7 days. That's it. So these are all the techniques that could be utilized in case coronary operation happens immediately after it happens. Thank you.
One of the fantastic cases, I think even if you do sometimes a delay to hear a suspicion, you do a IBIS to decide which of these left main or coronary should be stented prior to shutting them out. You have a suspicion, because sometimes the angiogram may not very clearly show whether it's going to occlude. Fantastic cases. I think the last one was good.
Would the moderators like to add anything?
I think all of us are hungry.
Thank you so much, sir. And we will now be moving on to our next session, which is going to be hosted by Dr. Kasparas Bredis, but he's going to be joining us virtually. And this session is going to be moderated by Dr. Harikrishnan P, Dr. Manohar, and Dr. Ashish Jha.
Yeah, we can hear you, but a little faintly. If you increase the volume a little bit, it'll be fine. Yeah. We can see your slides. Can you switch off the other mics? Is it going?
Good meeting today. So today I'll be presenting two presentations, and I will start with our feasibility study of the new Vienna TAVI system. So we have data from 6-month follow-up, and I'll present the results now. So the main aim of this study was to determine and evaluate the the safety of this new technology, and then also evaluating the clinical and hemodynamic performance of this technology in patients with a symptomatic calcified severe aortic valve stenosis. So all the objectives and endpoints were chosen based on recommendations by the VARC criteria. So if you look at this slide, you can see the study design, and it basically consists of 7 visits spread out across 2 phases over 1 year. So we initiated the trial with a feasibility study and enrolled 10 patients with symptomatic severe aortic valve stenosis. So basically it's a prospective, non-randomized, single-arm study which has 2 phases, and the second phase is pivotal study, which has already commenced, and we're recruiting the patients. So in feasibility study, we assessed the safety performance of the new technology and Vienna valve, and also the hemodynamic performance, and we also monitored for any adverse events in this trial. So this is the flow chart of the study, and you can clearly see that we screened 12 patients. We had some screening failures due to small femoral abscess, and 1 patient secondary decline for the enrollment. So as you see, we didn't find any cardiovascular mortality even to a 6-month follow-up. We did have 1 non-cardiovascular mortality at 5 months after the implantation, which was basically caused by the surgery done on renal carcinoma, which was complicated first. So, all the patients that were screened for this study had a NIHA classification of 2 and 3. We didn't find the NIHA 4 classification in any of the patients at the time of screening. 6 patients of 10 were male. Most of them had comorbidities such as hypertension, coronary artery disease, also dyslipidemia, and only 1 had a previous bypass graft surgery. 1 patient had also a permanent pacemaker implantation prior to the study investigational device implantation, and also 2 patients had atrial fibrillation. Also, when you look at the laboratory findings at the time of screening, many of the patients were in the compensated heart failure phase with the elevated NT-proBNP levels. Also, when you look at the Euroscore, we have the Euroscore 2 measurements for all the patients, and many of these were below 4%, meaning that they were in intermediate risk for having an open heart surgery. So then again, they went for a local heart team meeting, and these patients were deemed to have a high risk. And only 1 patient had an Euroscore 2 more than 4. So as I mentioned, we didn't have any NIHA classification before. And it's really important here maybe to mention that so 4 patients out of 10 already had syncopal events within the last 12 months at the time of enrollment. So we procedure, so we can clearly see that all patients underwent the general anesthesia. I would say we wanted to have a TOE guidance of the procedure, so for the patients to be more comfortable, we have them under general anesthesia, even though on a routine basis we do it with the conscious sedation. So as all the valves were basically really calcified ones, we wanted to have a good pre-dilatations, so we used pre-dilatation in all the cases. So we implanted 10 valves in 10 patients, and we used the valve sheathing function for 3 of the valves, and we wanted to have a desired anatomical location in the proper location. So also we didn't have done any kind of post-dilatation in any of the valves, so that means we had really good sealing of the aortic annulus within the stent frame, and we didn't find any significant PVL after the implantation. So also we've seen the free coronary perfusion in all the cases. So overall, the device success, which was defined by the correct positioning of a single device in a proper anatomical location and providing really good hemodynamics, was achieved in all the patients. And also technical success defined with the successful vascular access and successful retrieval of the delivery system was also achieved in all the patients. So basically we had one cardiac tamponade which was caused by the right ventricular basin lead perforation which required pericardial drainage, and the patient was fine afterwards. So if I may also mention the procedure time, it was 45 minutes, and I think this is a really good feature of this device, which will be discussed in a later presentation by Dr. Katerina. But you'll see that when you have a pre-mounted device already in your cath lab, so there is no steps that need to be having your valve to be cranked during the procedure. So in that time, you can also save some time for the procedure itself, and you can reduce your procedural time even less than 40 minutes if so. So when you look at this slide, we see that, as I mentioned before, we didn't find any cardiovascular mortality at 6 months. We had 2 strokes, which was one really acute after the implantation, but the patient underwent the interventional thrombectomy, and she recovered from the stroke after the intervention of the thrombectomy with no residual neurological deficit observed even at 6-month follow-up. And one stroke was a subacute stroke just 5 days after the implantation. So this was for the same patient which experienced the cardiac tamponade caused by the ventricular, by the basin lead perforation. So we didn't find any hospitalizations after the implantations for any of the patients related to any valvular symptoms or congestive heart failure, looking also to 6-month follow-up. We didn't need to have any repeat procedure for any of the patients. So we did find that one patient required a permanent pacemaker implantation because of the complete heart block, but the same patient was on the pre-existing right bundle branch block at the very beginning at the time of screening. So basically it's a high risk for pacemaker implantations with any of the TAVI devices. And also one patient experienced symptomatic sinus bradycardia like 1 day after the implantation, and we discussed and ended up having a permanent pacemaker implantation for this patient as well. So in this slide you can clearly see that the valve provides a really good hemodynamics. So even the mean pressure gradient from mean pressure gradient 48 goes down to single-digit numbers for all the patients, even to 7. And also a really large mean effective orifice area was achieved for all these patients. And I think that this is due to the supraannular design of this valve, which can give you a really good hemodynamics after implantation. So we did find one moderate aortic regurgitation, which was seen at the time of discharge on the ultrasound scan. But we didn't find total aortic regurgitation for this patient at 6-month follow-up, meaning that the valve stent frame was seen more after the discharge and might reduce the moderate PVL to be mild only, so based on the bar criteria. So some of the patients, as you see, were not followed up at 6 months. So the one patient, as you remember, had a good study due to non-cardiovascular death at 5 months. And the one patient had a subacute stroke, was not able to attend these visits for follow-ups. And always we want to have the benefits for the patients, so we want their quality of life to improve after the implantation. So we analyzed the Kansas City cardiomyopathy questionnaires, and it has a significant increase for all the patients, showing a better quality of life after implantation, which is lasting more than 6 months now. And also, we had some changes in the classification, but if you remember, we didn't find any patients to be in the class 4 at the time of screening who might get more benefits after the implantation. So basically, I want to conclude about our study and that our findings suggest that this device has a really good hemodynamic and clinical performance, and also it has a safety features for all the patients that were treated with this device, and which lasts more than 6 months. And I think we're enrolling more patients now in the pivotal study, so basically another 75 patients will be analyzed together for the other endpoints to obtain the market approval. So, thank you for your attention, and I'm just wondering if you have any questions right now, I'd like to answer.
Can you go ahead with your case presentations as well, and then we can have some questions?
Can someone unmute yourselves? I might hear any questions. So I'll try to carry on with the presentation. And so the valve prosthesis, as you can see here, it's already pre-printed on the liver system in the capsule. And Dr. Katrina will talk about this in upcoming slides. So what you can see under the X-ray, you see that the valve is in the capsule, and you can clearly see the capsule itself down here and the stent frame of the valve. So we basically want this stent to be just below the annulus, around 3 millimeters, and to cover the LVOT. And the same delivery system for the trip valve. So basically one knob, because you need to rotate clockwise for the valve to be fully released. And if you want to recapture the valve, you can just turn it counterclockwise. 16 French in the shaft and the 20 French in the distal end, where the capsule and the valve is printed. So I think it will be covered in upcoming slides. So basically, I'll be speaking about 2 first cases with this device. So I'll be covering 76-year-old male case who was deemed to be a high risk for implant surgery. So we decided to go for a TAVI procedure, and the patient were enrolled into the study. So based on the valve size, which was the biggest Vienna valve, so 31 millimeters, and I'll show you the CT scan afterwards. Some PCI was done to LAD, no residual stenosis were found, the patient with dyslipidemia, obesity, no particular medications. So he had an ECG with a borderline bundle branch block and a borderline PR interval at the time of screening. So we can see the numbers of the ultrasound scan and clearly see that the aortic valve was critically calcified with a really big mean gradients and peak gradients also. So it also can be seen here on ultrasound scans. So you see the velocity was reaching up to 6 meters per second, and a really big mass of left ventricle hypertrophy. No particular stenosis in the coronary arteries. So the CT scan, as you can clearly see, calcified aortic valve leaflets, some STJ calcification as well. So annulus annulus size was derived from the perimeter. It was 28 millimeters. The same was in LVOT level. So the calcification distribution was equal in most of the on all the leaflets. Some STJ calcification. The coronary heights were 14 and 23. So we carried on with the procedure. So you can see the TOV probe and a big calcium chunk at the annulus level, also at the mitral annulus. So we chose the lunar pismar for this patient, and we had a 24 balloon predilatation of this critical aortic valve stenosis. and he introduced the 31 millimeter valve in the left ventricle. So we tried to go to the test overlap view, as you can see on the left side. We wanted it to be as nominal as we can with our implantation depth around 3 millimeters. So we initiated the implantation. We've done some pacing of around 120 beats per minute during the implantation, just to reduce the cardiac output a little bit. And after we accepted the position, we released the valve really slowly, so we don't need to rush, the same as with the trip valve technology. You need to open up slowly, and you also have cardiac output already after 1/3 of the valve is being released out of the capsule. So we see the valve released, and no jump was observed. And the final result, as you see here, no PDL with implantation death, and the patient was discharged after 2 days. So ultrasound scan the next day, you see the good valve implantation, small or even trace PDL on the sides, and good valve expansion, and this really calcified aortic valve stenosis. So the velocity is downgraded to 1.6 of velocity, and the same was observed also at the 1-month follow-up and 3-month follow-up for this patient with a single-digit new gradients. So we also done the CT scan for this patient, showing that if you remember, it was really critically calcified aortic valve, which ended up with a really good implantation, and the expansion was really good without any post-dilatation necessary for any of the patients in all this cohort. So the second case, 84-year-old male, also high risk for open heart surgery, based on the CT scan, the 31 millimeter Vienna valve. So even though the perimeter divide was from 26, which would be borderline for 29 or 31, so what we wanted to have a better effective orifice area for all the patients, so we chose for the bigger one. So you see on the right side the tortuosity of the aorta, which is really intense, not only in the ascending aorta but also in the arch and descending. You see on the X-ray images, and we're able to pass this device. So some kinking in the right iliacs, the left was fine, so we chose the left side for us to proceed. So as you see here on the left image, the horizontal aorta was really intense, so we wanted to have our under-twist bar in place. We made a good dilatation with a 23 millimeter balloon, and we crossed the aortic arch with the TAVI device. As you can see here, even in this really horizontal aorta, we were able to go through calcified aortic valve and start our initial implantation. And on the right side, you can clearly see also the capsule itself, so you can distinguish where is the capsule and where is the stent frame, and you want the stent frame to cover around 3 millimeters or below the aortic angles. And here again, going into just overlap view, acquire the desired position. You start releasing the valve, no rush, so we have a cardiac output after 1/3 the valve is released, and as you can see on the right, the valve was fully released without any jump in the horizontal aorta. And the final result, with a really good result, and as you see, the tortuosity of the aorta was really intense for this exact patient. And TOE guidance, as we used in all the cases, so you see a really good expansion just 5 minutes after the implantation, the good leaf coaptation, and no PDL was observed in this patient as well. The same was observed at the 1-month follow-up with the single digits and really good radios of the device. So thank you very much for your attention, and if I hear any questions, I will answer.
Can you hear us?
Yes, I can hear.
So thank you for fantastic cases. So how was how long have you follow up on these cases?
So Rob, I cannot hear really what it is.
What is the follow-up? How long are you having the follow-up on these two cases? Can you hear us?
Yes, I can hear.
Thank you. Thank you very much. Is there any questions? Anybody want to ask any questions? I think it's fine. Thank you very much.
If you can hear me, I can answer this question because I only heard it. So basically, the longest follow-up where we have now is more than 1 year, and all the patients that were seen at 6-month follow-up, they are already ongoing for the 1 year follow-up. And the last patient will be having a 1 year follow-up in June this year.
Thank you very much.
Thank you very much, Kasparas. I promise I take 2 minutes and then we can all party, okay? So, I'll give a very short presentation just to make you understand the first in-human trial was still done with the first generation device. Now we are launching the second generation device, which has a super flexible delivery device and tantalum markers on the valve in order to be able to have your coronary alignment and also your depth control. So just very short, I promised. It's a supraannular valve design, self-expanding nitinol frame, bovine pericardial dry tissue, which means again it's an off-the-shelf solution. It's fully recapturable, retrievable, repositionable, and it's the only pre-mounted dry tissue ready-to-use system worldwide. Next slide. If you look at the design, then it comes in 4 sizes, able to cover an annulus size from 18 to more than 36. So it's, next slide, we will look at this in more detail. So if you look here, you have the 4 different sizes. You have the rather straight part here in order to have a better paravalvular sealing or better sealing and to prevent too much pressure on the conduction system in order to avoid pacemaker need. Next slide, please. As I said, annulus range from 18 to 29. I think this is important. The nominal depth that we are targeting is 3 mm below the annulus. Here, the minimum height 13 millimeters, but this is for the clinical trial. Of course, if you have a larger annulus, you can go below that, so that 10 millimeters of coronary height would be recommendable, and diameter of the coronary sinus plus 3 millimeter. Next slide, please. Advanced sealing. The valve has an outer skirt made of PTFE, which will improve the sealing and which will also, in the calcified situation, prevent paravalvular leakage. Next slide. I think this is very important because we have discussed this about the coronary access post implantation, and here you can clearly see that if you have the Evolut Pro on the right side and here the Vienna valve, that it favorably compares. I would say it is between the Navitor and the Evolut. Evolut is quite narrow stent cell design, 135 cells in total. Of course, the Navitor very open cell design, but less radial force. You always have to trade for one or the other. And then the Vienna valve, I would say, positioned in the middle from the cell design with overall 96 cells. And if you look here, this is always the 29 millimeter French valve. Then you have an 18 French access here and 13 French access here, which should be good enough for your coronary revascularization. Next slide. Bovine pericardium I already mentioned. Next slide, so we will skip this. Next, next, next. Yeah, these are, no, back. this I think is very important. This is the published data on the pericardium used in the different valves currently used. You can see the PNF, so the Vienna valve, the Abbott, Medtronic, Boston Scientific, and Edwards with their proprietary pericardiums. And you can see that only the Abbott and the PNF valve have the full range of treatment, so to reduce the free aldehydes, extract lipids, minimize cholesterol uptake, stabilization of the leaflet collagen, but then the last step, the dry storage, is only for the Vienna valve. There is no data available for the accurate. We know from the Boston, from the Medtronic valve, that there is only few steps, and Edwards as well. Next. This has been shown, so the next generation delivery device has a braided tube, has a braided capsula for enhanced flexibility, has very good torque, so I think it's very important that you are able to reach your target. This is why the second generation is now presented. Next step. Next. Next. I think this is it. This is one more important point, because I think everybody's aware that all in the industry is cheating about the French size, because everybody's measuring the inner French size, which of course will not help you if you have to cross a vessel. So these are the real French sizes measured in the outer diameter, and there you can see that the PNF, the Vienna valve, compares with the Evolut valve. Navitor is a little bit smaller from the diameter, but in the end it's the capsula of the device that will matter, because you will not be able to cross the vessel if you're only with the delivery device. You will always have to bring your valve in first, and this is why in reality it's the size of the capsule of the valve that matters. Next slide, please. This we have seen, it's a very low skirt with 8.4 millimeters. If you remember the image of the Evolut, you can see that this has a much higher skirt, other leaflet geometry. So this has a low skirt with a very favorable leaflet geometry, which also has a good openings if you look at the leaflet geometry from above. Next. The next generation, as I mentioned, will have tantalum markers in order to facilitate your coronary alignment as well as your depth control. Next slide. And this is how the valve is crimped on the delivery device. I think we go to the last slide because I promised 2 minutes. Next. Maybe I want to give the credit here to the first in man in India, which was published at the European Journal of Cardiology as a case report, and I think this was a great achievement already 2019 and published with wonderful results. Next slide. So in conclusion, there's a new generation with a super flexible delivery device, increased radial force for calcified anatomies, only pre-mounted dry tissue target system, and the reliable self-expanding technology. Thank you very much.
So thank you very much. Very impressive. Thank you.
So, yeah, I think it's just fair if you, no closing statements, sir? No. Would you like to share any closing statements? All right, with that, I think it's safe to say that we've now come to the end of the event. Thank you all so much for joining us, and please proceed for dinner. Thank you.
கட் பண்ணிட்டீங்களா? சாப்பாடு சாப்பாடு